Purposeful Lab. Purposeful Lab is a show produced by Franciscan University where we explore the purpose that's embedded in the universe and in our lives. And we do this through examining topics that are relevant to the culture at large. And I'm Dr. Dan Kuebler, your host for the Purposeful Lab. I'm a professor of biology here at Franciscan University. And this season, we are examining the topic, the nature of man and woman. And I'm joined today by Dr. Paul Hruz, who is a pediatric endocrinologist. And so we'll have him explain what that is and the expertise he has there and how that's relevant to our topic in a moment. But Dr. Hruz is an associate professor of pediatrics at the Washington University School of Medicine in St. Louis. He got his medical degree at the Medical University of Wisconsin. Ended up doing his residency at Washington University in Seattle, and then he moved to Washington University in St. Louis and has been there as a professor. And Dr. Hruz, welcome to the program.
It's my pleasure to be here.
Well, great. Maybe we could start just talking about what pediatric endocrinology is and what your research has been and what got you into the topic that we're going to discuss today, which is sort of this gender-affirming care that the medical community has towards individuals that have are struggling with sort of their gender identity. Right?
Oh, very good. Yeah, I'll begin by just sharing what I do as a pediatric endocrinologist. So endocrinology is the field of medicine that studies diseases of hormonal function. And hormones, by their definition, are substances that are produced in one area of the body that travel through the blood and act at a distant site. And the scope of endocrinology covers a wide range of diseases, including diabetes, disorders of puberty, growth, thyroid issues, and it includes issues of sexual function, sexual development. Throughout my career, I've been involved in the care of individuals that are born with ambiguous genitalia that have what we understand as disorders of sexual development. In addition to the many other areas that I have been involved in. As a physician scientist, I've also been involved in basic science research. This has included, the study of drugs and how they can affect normal metabolism. One of the areas of research that I was engaged in involved individuals that were receiving drugs for the treatment of HIV. So through that work, trying to prevent an off-target effect of that drug, became very acquainted with individuals that are dealing with questions related to their sexual identity and sexual orientation. And through my work in caring for these individuals that have disorders of sexual development, really have developed a desire to really help them in addressing their associated suffering. I got involved in this very heated topic of gender dysphoria at the time that I was serving as chief of our division of endocrinology, and had a member of my faculty request that we start a gender affirmation program at my university. And being a physician scientist and in my role in that capacity, it was necessary for me to look into what was being proposed as this novel form of intervention. I'm sure we're going to talk about that more today. But it has really forced me to look at what the science says and what it does not say, all directed toward, as we do in all areas of medicine, including my role as an endocrinologist, to alleviate suffering and to restore health.
Yeah, well, that's great. I think we definitely want to get into sort of gender dysphoria and sort of this gender-affirming care and what you've seen there. But I think before we dive into that, it would be good to just get an idea of how do these hormones play a role in sort of the development of sort of sexual characteristics, and then what role does that play in sexual identity that people have? And so what's sort of the normal process these hormones play that you see?
Well, so the question of really the question relates to how we form and we develop or differentiate into either male or female, and that is actually determined at the time of conception by the genetic information that is present in that contributed mostly by information on the Y chromosome, and it drives a very elegant developmental process by which a bipotential system will differentiate into the male or female forms. And part of that involves the differentiation of the primitive gonads into either ovaries or testes. And those gonads secrete specific hormones, testosterone and estrogen. And those hormones themselves will change the appearance of the external genitalia to give the forms that we recognize as male and female. And this is a very integrated and beautiful process. There are a number of factors that we've recently discovered as far as directing that process, both at the genetic and hormonal level. Unfortunately, this happens correctly in about 99.98% of individuals, so that at the time of birth, because of the action of not only the genetic signaling, but also the hormones that are being produced, that one can correctly recognize the sexual identity of that individual by looking at the appearance of the external genitalia. So that is really the role of the hormones themselves. It's if you have defects in hormone production, most often it's going to lead to either an over virilization of a female, so that having characteristics that look more male-like, or under virilization, so abnormal or incomplete development of, for example, the male phallus that's present normally.
Yeah. So the key there with this development is to get, one of these two gonads. You think of what's the purpose of sexual development is to produce, functioning sperm or functioning eggs or oocytes, right? But it seems like in certain cases, you said 99% of the time, 99.9% of the time, it sort of goes properly, but there are these cases where it doesn't, where, the hormones are produced aberrantly or at the wrong timing, and that causes the gonads not to develop properly, right? And so, there's people that argue, well, okay, well, that means there's these other sexes then. You have the male and you have the female sex, and then there's these other things that happen when things go awry, where you don't have, say, the genetics, the hormones, and the gonads all lining up, right? And so how would you respond to those people that would argue, hey, look, it messes up, and maybe this is a third, fourth, fifth, sixth sex?
Yeah, it's a common, at least currently, a claim that's made that sex can occur along a continuum. But what that fails to recognize is the fundamental purpose of sex. And this is not just in humans, it's across the entire animal kingdom. When we think about the role of male and female, it is for the purpose of reproduction. And to my knowledge, there are still two and only two gonads, the testes and the ovaries, that actually participate in that process. And so there's not an infinite number of gonads. And in these aberrations that occur, these defects in development don't negate that fundamental purpose. And so it's important to recognize that most of these individuals that have these disorders of sexual development have impaired or absent fertility. So they don't have that ability to participate fully in that process of reproduction. Many people make claims not only based upon this spectrum of ambiguity that can occur, but also try to cloud that understanding of sex in relation to reproduction by bringing in all sorts of other factors that, claiming that one has a brain sex or one has a genetic sex or hormonal sex or a phenotypic sex, the appearance of the genitalia, and all of that. All of those claims are really rest upon a failure to recognize that all of what we talk about in this biological process is geared toward this reproductive purpose. And I think the only way that one can make those claims is if one forgets that.
Yeah. So it's the ends of the reproductive system is to produce the eggs and the sperm to allow for reproduction, and there isn't a third functional entity that comes out of it. It's sort of anything that gets disrupted, you don't end up with a third functional anything. It's either egg, sperm, or it's sort of defective. Now, what is then sort of the clinical response to, say, intersex individuals, where you've talked about your treatment of these people that have ambiguous genitalia? How frequently do people have that? Because you hear statistics all over the map of that, where some people argue it's very, very common, other people argue it's very, very rare. I guess it really depends on how you define that. And so, in your medical opinion, how frequent is that? And then how do you address those people that have sort of intersex conditions?
Yes, I think it's important to recognize that in these rare circumstances, and really it is about 0.02% of the time, a very rare condition where at the time of birth, when most parents will ask the question, if they don't find out in the prenatal ultrasound, is it a boy or a girl, that the physician will need to respond, I don't know. There are many that try to include defects in the developmental process where there really is no question about that sexual identity, but there is a defect in the formation of the genitalia, and that can include simple things like the something called hypospadias, where the position of the urethra is abnormally placed, but that's not really what we're talking about in these conditions. It's a very rare condition, and the role of the physician in addressing that issue is twofold. One, it is try to understand what went wrong, what was the cause of this aberrant development, and then to, as best as possible, restore health. And there's really important reasons for addressing both of those concerns. The first of recognizing the cause is there are many of the disorders that are due to defects that can have life-threatening complications for that individual. For example, something called adrenal hyperplasia, where there's a defect in your ability to make the sex steroid hormones that can put somebody at risk of having very severe defects in their body salts or electrolytes, and adrenal insufficiency, so that they can actually die if they're not correctly recognized and treated. And I think it's very important, to recognize that these individuals, if we can understand what went wrong, we can direct a therapy that is for the purpose of restoring that defect where possible. Now, there are some situations where there remains some ambiguity. We don't have a clear answer to that question. And there's, in those cases, what we try to do is the best we can to make predictions about how one might be able to function either in the male or female roles, and making our best efforts to be able to understand the true sexual identity of that individual. But again, it's a goal of restoring one to health, as we do in medicine, when we're confronted with something that is not functioning in the way that it nor is the purpose of that differentiation.
Yeah, and in those rare intersex conditions, how easy, you mentioned you're trying to restore health, how easy is that to do? It seems like a lot of cases you're not going to be able to restore at least the reproductive function in some of these cases, but you're trying to help alleviate some of the other symptoms that occur when the development doesn't go properly. Is that a correct assessment of that?
That is correct. So that, for example, the case of the adrenal hyperplasia, where it can affect, most often it'll affect a female that has virilization, so they'll have an appearance that looks like male-like, that they will have fertility and they will be able to do well if we can administer the hormones that are missing. So we would give a hormone known as cortisol or hydrocortisone to be able to address the problem of adrenal insufficiency and to be able to prevent the ongoing production of those androgens or male type hormones. are some situations where there is a defect in the ability to respond to the hormones, and that makes it very difficult to treat by giving the hormones themselves. It may influence how we address that problem. But we always will continue to evaluate over time. So there are some conditions that are not clear at the time of birth, but become more apparent later in life, and our ability to intervene becomes better. And there's generally a movement in the medical profession. We used to think that we needed to make an immediate determination of the sexual identity of that individual, and then sometimes we would intervene by surgery to change the appearance of the genitalia. The field has recognized that unless the structural abnormality is creating other health issues, and there are situations where that occurs, that the best approach is to be very cautious and to wait so we can understand better, how they are developing and how they will function. For example, if some of the conditions by having gonads that are not properly formed are at risk of becoming cancerous, and certainly we need to intervene and prevent cancer from developing. Or, they may be at risk of infections because of the plumbing, the anatomy may predispose to that, and that may require intervention. But aside from that, we do our best to continue to work with that individual and with their family to be able to understand and make prudent decisions about how we can restore as best we can sexual function.
Yeah, so we've been talking about how to restore sexual function in intersex individuals and how you would medically treat those individuals. How does that, because I think there's a lot of confusion sometimes about what intersex is versus this gender dysphoria. And people often confuse those terms and think, oh, if someone has gender dysphoria, they're intersex and so forth. There seems to be this increase in sort of people that identify with having gender dysphoria. So could you just explain the difference between those two? And then maybe also talk about how that term gender dysphoria has developed over time.
Maybe I can begin by at least pointing out, some of the terminology that we use is very important, and even the way we refer to these conditions has changed over time, and there are some that still use the term intersex. But again, that feeds into that understanding that there is possibly a third sex. So I think that the physicians usually will refer to them as DSDs for disorders of sexual development. There are many that want to take away stigma by in not calling it a disorder by a technical understanding of what is going on. I think we can classify it as truly a disorder, but they'll use the same term of DSD and talk about differences in sexual development. It is important to recognize that in this condition where individuals have a sex discordant gender identity, meaning that they have a perception of who they are in their sexuality that is not in alignment with their biological sex, that the vast majority of individuals that have that experience have normally formed and functioning gonads and genitalia and all of the reproductive system, at least prior to any medical interventions that are done to address the dysphoria. So, that
they really
are distinct.
Someone with a disorder of sexual development, they wouldn't fall in that DSD category.
They would not fall into the category of having a DSD, but people will draw attention to the DSDs to make a goal of that these individuals fit within something that is biologically determined. And again, this gets at the question of what is the cause or the etiology of this known phenomenon where some individuals have this experience of a sex discordant gender identity. And, we can talk a lot about what we know and perhaps more importantly, what we don't know about what leads to that experience. We know that the demographics have changed drastically over the last few decades. It used to be an incredibly rare condition, this gender dysphoria. dysphoria. And we've seen really almost an exponential rise in the number of individuals that have this experience. And many will ask questions or propose hypotheses as to why that may be the case. There probably are genetic determinants. I'm sorry, there are genetic influences, but not determinants of this condition. So when we look at some of the data, for example, looking at a concordance with identical twins, when we look at if you have one individual that is genetically identical to a sibling, what is the likelihood that they will both have that condition or not? And this gets at heritability, and we know that there are many other conditions, psychological conditions, like alcoholism and compulsive gambling that have some heritability, but it's not a determinant. So there are factors that may predispose them. So I don't think we can use that data to say that this is something that's genetically determined. There's no evidence that statement can be made. There are theories about environmental contributors, and this can be exposure to underlying psychosocial or psychological stress, whether physical, emotional abuse, a whole host of different conditions. An interesting association with individuals that have autism and have this condition as well, and some theories about why that may be the case. And then perhaps the most contentious hypothesis is the role of social media and,
Right. Yeah,
and
you've heard
the
that.
environment in being able to drive this.
Yeah. So you said you got into this area, particularly when, while she was setting up a clinic to deal with people that had gender dysphoria and so forth. So what is it, somebody comes in, what is sort of in the U.S., sort of the way the medical community has been brought in to treat gender dysphoria? What's sort of the standard way that it tends to be done now in the U.S.? I know there's probably, it's changing and so forth in some places, but say when you started this, when they started the clinic, what would the physicians do when someone came in with this? What was sort of the standard practice that you saw?
Yes. So the whole question of why myself as an endocrinologist had been pulled into this particular field in addressing this condition is that there was a proposal that was based upon a premise that when this sex discordant gender identification occurred, it was really a paradigm shift from the way we had always understood this condition, that the mind is not the problem, that things are psychologically are working normally, and that because of that the body itself presented the problem. So there was an effort to change, or there is the effort to change the appearance of the body to conform to one's gender identity. And so because endocrinologists have a toolbox, they have tools in giving both hormones that can shut down normally timed puberty or to give estrogen or testosterone to an individual that will change the appearance of the body. That is how my profession was drawn into this conversation and addressing these individuals that have that experience. That really it had started, several decades ago, but it really has taken off very recently in the last 10 to 20 years. And again, it's based upon a premise that can't be proven scientifically, but it can be tested as far as whether it provides benefit or not to these individuals. So when I was first challenged with the desire from an individual from my institution wanting to start this new what's called the affirmative approach to care, which actually contrasts with the prior approaches that were either directed toward helping an individual understand some of the influences that led to this experience at the psychological level, or merely to support them in their journey as they would come, to realization that this was an issue that was temporary and not permanent. to help them along the way, shifting into this medical paradigm. And so, there's much that has been written about this, but unfortunately, as I looked into the literature and the science behind this fairly novel approach, many questions were apparent that had not yet been answered. So, as far as what we were doing, the basis of why we were proposing that this would be helpful, and then looking at the data as to whether it really was helpful, in consideration as we do as physicians in other areas of medicine, to really do a very careful risk-benefit analysis. We do this in other areas of medicine as well.
Yeah, so this gender sort of affirming care is saying, oh, we need to, change the hormones and change the anatomy of the body to agree with sort of what the person is thinking or wants to identify their sex. And you often hear like, this is it's safe and it's effective in treating these individuals, right? And particularly, a lot of this treatment is done to children, their teen years, and so. Could you speak to, what is the evidence that we have as whether this is scientific evidence, medical evidence, that this is actually working or not working and in treating these individuals?
And that's a very, very important question and to address. And there actually has been more recently internationally a critical appraisal in a very systematic way of that literature. Several what we call systematic reviews have been done in some European countries, including in Sweden and in Finland and most recently in the United Kingdom. And really the conclusions that were reached supported exactly the conclusion that I had reached when I looked at the data as well, that the evidentiary base was very weak. It was based upon many times flawed or very limited study methodologies, and that the outcomes that were being reported to make the claims that this was safe and reversible were not borne out by the data themselves. So just before I get into addressing some of the risks that and the basis for the risks that occur with this intervention, to speak about what are those limitations in the science. And this is very important in all areas of medicine. We know that sometimes we will engage in medical interventions with limited data, but there's always a balance of how aggressive we are in pursuing a novel intervention based upon the risk of that intervention. So the higher the risk, the higher the data that we will require to proceed in that area. So most of the studies that have been published are based upon very small sample sizes. There are significant biases that are present in how patients are recruited to the studies. Many times they have inappropriate or no control groups. They're often short in duration. They use study methodologies such as cross-sectional surveys, which at best can show associations, but not a causal relationship between the intervention and the response. And there are many patients that are lost to follow-up, and that's a serious limitation of research. And not acknowledging that, I think, is detrimental, to moving this field forward. And unfortunately, the systematic reviews that have been done have acknowledged this, and there's been a call, to really increase the rigor of the scientific studies that are being done. And really another factor is that there's often confounders that aren't being considered. And I think that in any of the studies that even show a modest benefit, there's not a control for what the psychological interventions may or may not have contributed to that particular outcome. When we look at risk and benefit, they're just fundamentally understanding it, particularly in the area of hormone administration. It's not the same thing to give estrogen to a male as it is to give it to a female, or giving testosterone to a female. The basis for that is it has to do with sexual differences that are not present only within the genitalia or the gonads. The sexual differences that are present between males and females is present throughout the entire body, and it's due to genetic differences and what we call epigenetics in how genes are turned on and off in response to various signals. This is well recognized. It's been known in medicine for many, many decades. There's been whole textbooks that have been written about sex specific medicine, meaning that that when you're investigating, for example, a new drug, that if you study males and females, you may get very different results as far as the risk profile or response to treatment. So it's not surprising then that when we are looking at these interventions that we're going to see adverse effects because of that, or at least raise concerns about effects. For example, giving estrogen to a male will increase the risk of suffering stroke from clots, something called thromboembolism. There is changes in the risk for heart disease or metabolic risk of developing diabetes. And probably the most significant risk is that, as we mentioned earlier, that most of these individuals that are coming for this intervention at the start have normally formed and functioning reproductive organs. And in the process of intervening, we actually will impair fertility or actually in some situations, will sterilize that individual for life, depending on the intervention that's given and when it's given. And that's a serious side effect. And so to say that this is safe.
Typically, what age are these individuals when you're doing this? Just in general across the U.S. So what age are they when you're targeting this, where they have these risks that you're exposing to, and sort of the point of infertility being one of the side effects of these treatments? So when are these decisions being made? Because I think it's important fact.
The risk occurs really anytime they're administered, but particularly when they're being administered to children. So the first stage of intervention from a medical standpoint is to interrupt normally timed puberty. And that is to give medicines that will suppress the normal signaling from the brain, the pituitary gland, to the gonad. They're called puberty blockers in the cultural conversation. They're called GnRH agonists from the medical community. And that would begin when puberty begins in these individuals. So normal puberty for females can begin as early as 8 years of age and 9 years, for boys. And so some instances, these medications are being administered to children at those ages. When one looks at the data, it's not only that they are started on these medications. It's often claimed that it's a temporary pause, so to allow them more time to explore their gender identity. But when one looks at the data, nearly all of the individuals that start on puberty blockers will proceed on to later stages of the affirmation approach, so the cross-sex hormones. And when you expose an immature gonad, don't allow it to fully mature during that pubertal process, and you expose it to these very high levels of hormones that are not normally seen in a male or a female, the expected response is to disrupt and potentially sterilize that individual for life. Maybe when it's introduced later, after the gonads have developed, there may be less effects on the gonadal function, but there still are concerns. And in fact, those that are offering these interventions will counsel individuals about this likelihood of occurring. One can ask many questions about whether the child at that age is able to understand what they're giving up usually, but these risks are very real. There are risks throughout the exposure, but they become more important and more magnified the younger that they're introduced.
Yeah, so it seems like the approach would be to block puberty, give them time to think about it, and then, but as you say, most of them then go on to this sex hormones, and then the third stage would be some type of surgery to match the genitalia to their sort of the cross-sex hormones that they're taking. So it's sort of a three-stage approach. And you always, is that typical? And then one of the things that you always hear is, well, this helps with their mental health and reduces suicide. He says, oh, they're better off, they're less likely. And that's one of the the biggest concerns with these individuals that struggle with this is the risk of suicide. And is there actually strong evidence or any evidence that doing that approach does prevent mental health, particularly suicide, in these young people?
Very important question to address, and really, those that are offering this intervention often will acknowledge, the risks associated, and they will indeed make that claim. So we don't have good long-term data on the children that have been exposed to these interventions. Most of what we have are shorter-term data. In the long-term data that's been published in adults, so those that began the affirmative approach after they've completed puberty, often after 18 years of age. And these are population-based studies that avoid some of the recruitment biases that I mentioned earlier. For example, in Sweden, where they collect the medical records of everyone in that country, so there's no recruitment bias. Long term, this risk of suicide remains elevated above the background population. In fact, in that Swedish study, there's nearly a 20-fold increase in completed suicides in individuals decades after undergoing this affirmative approach. Now, that study itself was not controlled, so one can't say what the intervention itself did to that, but one can say with confidence that it didn't fix the problem. It's not to, and so if we look at suicidality, so there's a difference between one thinking about, contemplating, or engaging in behavior, that we would call, suicidal risk versus completed suicides. The data itself doesn't really fit the claims that are being made. So first, one needs to distinguish what of the suicide risk is due to gender dysphoria versus the other comorbidities that individuals experience. There's a high association of mental health issues such as depression, anxiety, eating disorders, and other conditions in this population. Many times those psychological difficulties preceded the onset of gender dysphoria. Many questions about what is the chicken or the egg in this, and many claims that are made that are not supported by science. And when one looks at suicidality, suicidal ideation and attempt, one finds that actually the rate is comparable to those that do not have gender dysphoria, but have these other psychological issues such as depression. So it's not we need to acknowledge that this is a serious problem and not to minimize it, but we have to question whether it's the gender dysphoria itself that is driving that statistic. Then we need to look at the statistic of actual completed suicides, and so that's a very, very small number. It's often magnified. And we want to do everything we can, to address that potential. Most of the individuals, will not have that outcome if they're not affirmed. We don't have the data that we would like to directly compare with and without the interventions. And one of the studies that is yet to be done is to, in a very rigorous way, look at the influence of addressing the psychological issues by themselves as to whether we might be able to alleviate that. So again, in medicine, we always look at, non-inferiority, or we look at, if we have means of intervening that have less risk, but same or greater benefit, that would be preferable. And I think that the argument that psychological interventions are not effective is based upon a bias, and not upon an objective investigation of whether that will or will not work. And there is evidence that these underlying psychological issues can be addressed by just regular good practice. Again, I'm an endocrinologist, not a psychologist, but my psychology colleagues, can address that in greater detail.
Yeah, there certainly seems to be a lot less risk if you address the underlying psychological conditions as opposed to these medical interventions. You point out all of the risks of these cross hormones that you have, and then the obvious the ultimate risk of sort of infertility there. It seems there's a sort of a change in approach in Europe. There's like that they've a lot of these studies are coming from European countries where they have bigger data sets and are able to sort of the nationalized medicine. They can see what the outcomes are and say, hey, we're not getting good outcomes with this, and there's sort of a change. Is that true? And is that something you see starting to affect the practice in the U.S., where they're looking towards, hey, let's push pause on this more drastic interventions?
Yeah. Yeah. So, as I mentioned earlier, there are very good systematic reviews of the literature base, and there's also been concerns, and probably most prominent has been the ongoing dialogue in the United Kingdom from something known as the Cass report, where they did a number of systematic reviews addressing several questions in the care of individuals. Many that were involved in the treatment of individuals in that country began to recognize that the outcomes that were hoped for were not being achieved. There were many individuals that continued to suffer. And there has been, there's been a recognition that what is going on in this affirmative approach really still resides within the realm of experimentation. There are questions that need to be addressed. And so they're really requiring that those that are offered this affirmative approach are done, that is done within the setting of a controlled clinical trial. And there's a greater effort to prioritize the psychological interventions that prudence would dictate don't carry the same risk that these medical interventions of puberty blockers and cross-sex hormones and surgery would pose to that individual. Here in the United States, again, much of this area and why it's so controversial is that it's been politicized to a great extent. There's many that are operating by ideological principles rather than basic principles of best practice of medicine, evidence-based medicine. And they've tended to disregard or have been unwilling to accept the conclusions that were reached by those European countries. Many of my colleagues have recognized the concerns, about the evidence and what is going on, but because of the dynamic in our culture, they've been reluctant to express those concerns publicly. That is starting to shift. For example, recently, the Plastic Surgeon Society came out with a statement, questioning this intervention. It's the very first in the United States that has recognized those concerns that are being expressed in Europe. The American Academy of Pediatrics and the American Psychological Society have not yet been willing to recognize that. In fact, they've been doubling down on their claims based upon those weak scientific studies that I mentioned earlier.
Yeah, you've been speaking widely on this and written on this topic. I just wonder, what is the response that you've gotten sort of off the record from other doctors about this? Do they seem to recognize, like you said, that maybe there's something awry here and don't want to speak publicly about it, or are you getting a lot of pushback from the medical community? Or obviously there's this wider political pushback, I think, that I'm sure you're getting, but I'm more interested in sort of what your take is on where sort of the medical community is, particularly, it's interesting that the Plastic Surgery Society came out with a statement, like you said. But what do you hear from people off the record in a sense? Is it?
Well, I think so. There are some elements, and again, there's been a lot of ideological capture by the medical societies, and so when one says that the American Academy of Pediatrics, supports this, or the Pediatric Endocrine Society, supports this affirmative model, what it really is saying is that a very small subset of that community that's on a self-selected advocacy committee has made these recommendations, and it's not been really put to the entire vote of the membership. It's interesting that in the Endocrine Society came out with a position statement on sex as a biological variable, recognizing these differences between male and female responses to medications and disease susceptibility. That document actually went out to the full membership for comment. It was the first time in my career that we've had the opportunity, recognizing that it was going to be viewed as controversial, even though it's talking about basic understanding of biology. But that never occurred when the Endocrine Society guidelines were published for this recommending the affirmative model. It's interesting that in all areas, in academia in general, right, at universities and certainly in medical schools, that science works best when there's a back and forth. There are different hypotheses that are presented, and one is forced to consider the merits of the statements that are being made, and doing that in a very rigorous way. That has largely been suppressed here in the United States at many different levels. And in fact, when those that are the advocates for this affirmative model are speaking and they're confronted with this poor quality of evidence, the risks, the risk-benefit analysis, very frequently, they will not address the science itself, and they will resort to what's known as ad hominem attacks. So they'll, try to discredit the person, raising the concerns rather than addressing the concerns themselves. And I always like to remind my students that when somebody does that, they've conceded that they don't have an ability to respond, to the concerns that are being made. I think over time, the truth, whatever is going on, this risk-benefit analysis, whether they're alternative modes, if we continue to pursue that, we will, and this is what's happening in Europe as well. So despite the efforts to believe that the affirmative approach was the best approach forward, the patients themselves that were in front of these practitioners could not be ignored. And I think we're starting to see more and more of that, more individuals similar to the medical profession that has been largely silenced in raising these questions. Those that have gone through this affirmative approach to care that later discovered that it didn't fix the problem that they had, that nobody actually took the time, to investigate whether there are alternative reasons for them presenting with gender dysphoria. There were attempts to silence them as well, and it's a very difficult experience for those that are making that journey. But fortunately, we're hearing more and more of the stories of individuals that their own experience, and I think that that's going to be very difficult to ignore.
Yeah. And eventually, the scientific data, you hope reality wins out in the end. What does the data actually show? And as that comes to light, maybe some of this stuff will be reassessed about what we're doing and what we've rushed into. We have on this season, as we talk about this topic, we'll have some theologians and philosophers. But I did want to get your take. A great overview of sort of this from a medical perspective, and very much appreciate that. But as a Catholic, what do you think the church, what unique perspective does it have to shed light on this issue in terms of, a positive vision of male and female, and how that might resonate with what you see medically?
I think it's really important to recognize that there are many different dimensions to this problem of sex discordant, gender identification, or even understanding what sexual identity is. And what a scientist and a physician can contribute to the conversation is complementary, to what a philosopher or theologian may be able to contribute to the conversation. They're not in opposition. They're in harmony, but they use different tools and different methodologies to help address, this very, very important question. Two aspects, I think, of the understanding of human sexuality that we can know from at a biological level. I would say, fit very elegantly, very beautifully into the understanding of the theology of male and female and how we were created as male and female. One relates to this uniqueness of our complementarity as male and female. The sexual identity of an individual, the organ system, the reproductive system, is only complete with two individuals. It's the only system in the entire body that is not complete within one individual. So I don't have a complete I don't have a complete reproductive system. I have the male half of the reproductive system, and the female has the female half of that. That necessitates one to have that completeness to go outside of an individual. So it necessitates going outside of oneself. And what the church addresses in the area of love. Love is inherently directed to the good of another individual. So I think you can see a complementarity in that biological understanding of male and female that mirrors what a theologian may contribute to that conversation. It's very revealing, that when we talk about these sex-based differences, that they speak to a giftedness that an individual has as male and female. So that at the biological level, it allows males to fulfill a particular purpose, and I would say not just in reproducing, but also in contributing to the rearing of the children that come from that sexual encounter. And I think that the theological dimension to elevating the beauty of that relationship speaks very much in alignment with what the biology says.
Yeah, that's great how you see, you can approach the truth, and there's this unity of truth as, science can complement what we can know by faith, and the theology and philosophy, and can enlighten sort of our knowledge of the topic that we pursue via medicine and science. And hopefully we can get to sort of a wider wisdom on this by taking all these disciplines and integrating our knowledge. So I love what you had to say there on that. So just in conclusion, if maybe you can give our listeners some direction of where to go if they want to get more information about the medical data that you shared about these treatments. So.
Fortunately, there's a growing number of resources that are available that address the topics that we discussed here, including the poor scientific evidence and concerns about analyzing risk and benefit. For those that want to dig deeply into the science itself, there is an organization known as the Society for Evidence-Based Gender Medicine, or SEGM, that has taken the effort to critically analyze many of these papers, and one can provide or understand at a deeper level some of those. If one wants just merely a review, I did publish a paper in a journal known as the Lineaker Quarterly that addresses in summary form the concerns with the evidence that is being used to support the affirmative model. If one wants to gather read more about the question of pubertal blockade. Several years ago, I published a paper in the New Atlantis that is freely available online that goes into great detail on that as well. And then in a more broad presentation, I think one of the better resources out there is known as the Person and Identity Project, that it's all one word. One can search for that on the web and find information that does cover some of the medical aspects, but it also covers other dimensions of this concern about gender dysphoria.
Yeah, that's great. I know if you just Google Dr. Paul Hruz and New Atlantis, that article, it's a great article, will come up. And the Lineaker Quarterly is the journal of the Catholic Medical Association, so you could find that article you're referring to there. So. Dr. Hruz, we really appreciate your time and your expertise, sharing your expertise with us on this subject. So thank you for joining us.
Well, thank you very much for hosting this. It's, again, a very important topic, and encourage the listeners to also listen to the other episodes in this series.
Yeah, great. And so listeners, we hope you can join us for our future episodes of this season, where we explore the nature of man and woman here on the Purposeful Lab Show. Thank you.